Hello, my name is Ruben Mesa, and I'm the Executive Director of the Atrium Health Wake Forest Baptist Comprehensive Cancer Center. And delighted to be joined by this wonderful panel of experts in myeloproliferative neoplasms for us to take a deep dive in myelofibrosis. We're grateful to Blood Cancer Today for us to be able to share with you some of the exciting updates on the diagnosis and therapy of patients with myelofibrosis. So before we pivot to our main focus, which is on medical therapy, let's just delve a little bit in terms of the transplant piece. So at the current time, maybe I'll ask yourself, Toyosi, do you see any patients that go directly to transplant without at least having JAK inhibition kind of during the workup, or is JAK inhibitor kind of in every patient?
So I will say now that we are firmly in the era of JAK inhibitor therapy for myelofibrosis, it is exceedingly rare, in my own experience, for patients to go directly to transplant without having been on a JAK inhibitor. Part of that is very practical. Just because the patient walks in today and they have, say, higher risk myelofibrosis and they're otherwise transplant eligible doesn't mean that they can immediately get a transplant. They have to be worked up for that. We have to get insurance approval. We have to find a donor. The patient may have symptomatic splenomegaly and have to have that addressed. So what I tell my patients is that we will do these things in parallel. You will get medical therapy for your myelofibrosis while we are simultaneously working you up for a transplant, and then we can kind of move seamlessly into that. The exception to that sort of general rule will be once in a while I will have patients who are referred who, actually may not have much of a spleen at all in terms of palpable splenomegaly, but where their biggest issue is cytopenias, so transfusion-dependent anemia and or thrombocytopenia. And in those patients, I really don't see that putting them on a JAK inhibitor is going to have a lot of extra benefit if they were otherwise immediately eligible for a transplant. I'd rather focus my efforts on trying to get them quickly to the transplant. And I know we'll get into treatment of cytopenic myelofibrosis at some point, but if they are transplant eligible, I prefer to go straight.
I would very much agree. I think, patients that we're sending to transplant, the majority are going to have a JAK inhibitor. I would say that that's fairly typical, but you're right. There may be exceptions, particularly in terms of their phenotype. So before we kind of dive into the meat about our 4 approved JAK inhibitors, let me kind of flip to kind of the other side. So transplant kind of on the advanced, more aggressive, higher risk group. Naveen, do you think that there is a case for observation in any myelofibrosis patients at the moment?
Yeah, there is a subset of patients, maybe quite large actually, who have what we would consider low risk. So you're right, we've been talking about intermediate to high risk, but on these scoring systems, it is low, usually intermediate 1, intermediate 2, high risk. Maybe some of the other ones have a very high risk. But in the low and even some of the intermediate 1 risk myelofibrosis patients, you're exactly right. There is a group of those patients who either phenotypically, if you will, act as if they're ET, essential thrombocytosis, or PV, so earlier, or in fact, they did have ET or PV and are still in the low risk intermediate stage. Generally, those patients will have no or reduced spleen. They will have minimal MPN symptom burden. They will not have anemia. They won't have any of these major risk factors. And in fact, they'll score either 0 or 1 or whatever to make a low risk. So it's very important what you said. So in our do no harm model, CLL is another example of this, where there is a segment of patients where we can observe, sometimes for decades in some of these low risk patients. And so it's imperative on us to figure out before treating who needs treatment and who doesn't.
Wonderful. And Sanam, I know that it can frequently confuse folks, this issue of kind of early myelofibrosis versus low-risk myelofibrosis,
Yes.
which is a kind of a distinct entity. How would you frame for folks in a way that sometimes can help to clarify that? What do we mean by early myelofibrosis? And how might they be able to kind of distinguish those two?
Absolutely. So I think this goes back to what you initially very astutely pointed out, is having a comprehensive workup, right? Because early myelofibrosis can still be molecularly and genetically high risk. It's just that it hasn't gotten to the point of being a fibrotic bone marrow yet, right? But you can have a pre-fibrotic, because remember, this is a gradual process. Even if you have a molecularly high risk myelofibrosis, it'll take time for the bone marrow to become fibrotic. So if you're lucky enough to catch that patient early, you may not have a completely fibrotic bone marrow yet, but that patient may already have an ASXL1 mutation, may have or cytogenetically complex disease. So that patient is still destined to have, a poor outcome. It's just that they're not there yet. So I think, those patients are probably the ones that you want to watch closely, and you may want to intervene earlier for it, HLA type them earlier. So.
Wonderful. Well, that's a very helpful clarification. As you see clonal evolution, what are the things that you're finding are the most associated with really a more aggressive phenotype? This pattern looks different. If you're thinking of transplant, maybe you should start, moving in that direction.
Right. So I would say, unfortunately, the most common, secondary mutation that we see that dictates a very poor outcome is TP53, right? Mm-hmm. And that's the most common phenotype in these patients that have blast phase MPN. IDH, you can acquire IDH mutations, which now may not be a terrible thing with, having the IDH inhibitors. It may give the patient another avenue for therapy. But I think by far, TP53 is probably the most important. And, I think we should use this to advocate for serial NGS, for serial monitoring of these patients, particularly if there's a clinical indication that their disease is progressing. Right? I think they should definitely get resequenced so that, again, given that we don't really have a great tool to treat TP53 mutated MPN, but at least you can get them ready for a transplant. You know that they're probably going to, go into blast phase at some point.
Strongly agree.